So I was asked to talk about the future, and in particular, how to make sense in decisions about treatment, a little bit about drug resistance, and then some brief words about clinical trials. So I always like to start with this slide because when I was a fellow, also in University of California, but up north, we just basically had those first two columns of drugs, steroids and conventional chemo. So in the last 2 decades, we've had 5 new columns of drugs approved with multiple drugs within each class. And that's really impressive for cancer that's not super common. So this isn't breast, lung, prostate, colon, which are very, very common, and there's a lot of work being done. And I think part of the progress here is first and foremost because of patients, because if patients didn't participate in clinical trial, every drug that had approval here required patients participating in studies. It requires nonprofits, folks like Myeloma Crowd, academia, the FDA, and for pharmaceutical companies. So a lot of stakeholders, and if we didn't all collaborate, this would not be possible. But when you have this many drugs, it also generates a lot of questions, because what is the right combination and sequence? And I've shown at the bottom other drugs that actually don't necessarily have myeloma approval, but have shown some activity in the ability to overcome drug resistance or in combination with the drugs in that class. So we have a lot of choices here. And so what are the factors we need to consider in picking a drug? And these factors are not unique to myeloma, but at a high level, we have to think about patient factors, disease factors, and treatment factors. So you heard Dr. Costello talk about some of the standard drugs, but how do we pick, and we had that table, how do you pick from all of that? So patient factors, age and frailty is super important. In oncology, we're moving away from age and more to frailty. And you heard earlier Jenny talk about fitness. I ask all of my patients to be as active as possible. In fact, I think one of the most gratifying things about treating myeloma patients is when you see somebody come in with severe bone pain in a wheelchair, and then within a few months they're on the elliptical. As a healthcare provider, there's really nothing more gratifying than seeing that. But then I'm also on people's case to start moving when they are not, when there's no reason not to be, right? So sometimes I think it requires a little bit of a motivation, but that's a huge part because we come up with all these great clinical trials for patients with a median age of 65, and then we're sitting in the patient in clinic with a median age of 85, right? So can you treat, and actually to that point, my youngest patient with myeloma was diagnosed at age 18, and my oldest is over 100. And so how do you treat patients all the same when you have this kind of heterogeneity? And it goes back to what we were talking about earlier, right? Trying to personalize myeloma therapy, looking at age, looking at genetics, looking at all of these factors. So other patient factors that are listed here are renal function, because 1/3 of myeloma patients can present with renal insufficiency. And when you take a drug, it's typically processed by the liver and kidney. So if the kidneys are not working well, there may be a higher effective drug delivery. That's not true of all drugs, but in somebody with kidney dysfunction, you have to pick the right drug for that patient so that you're not overdosing them. Caregiver support. I know there's a lot of caregivers here. I think that's super important. I actually think our social workers should do a study about it. One of the classes that I had in med school many years ago was a funny title. It was, is it cancer and can I still have sex? The 2 questions that patients had, but that people didn't want to ask. And what you learn in that class is that in that first cancer visit, 50% of the information that's given goes in the patient's ear and out the other, because they're the only person in the room dealing with the emotional component of being told that they have cancer. And so yes, we're rattling off chemotherapy, drugs, doses, schedules, side effects, but what is really being retained? And you need that other person in the room. And I would bet money that patients who have support, social support, do better than those who don't. And we have, unfortunately, patients who don't have that social support. And when you give these complicated 3-4 drug schedules with a lot of drugs to prevent side effects, it's very hard to comply with all of that. Comorbidities, we know that as patients get older, there are additional problems that are unrelated to myeloma. In particular, cardiac issues is a huge problem. Myeloma patients have a higher risk of cardiac issues compared to age-matched controls. So, and that's probably because of multiple factors. Kidney disease can contribute to cardiac issues. Pain can increase blood pressure, which can contribute to cardiac disease. 10% of patients with myeloma also have amyloid, and so amyloid can affect the heart. So a lot of factors. Chronic anemia is another stress on the heart. So then we move to the disease. We talked a little bit about staging, but especially if somebody's relapsing, is this a biochemical increase, which means the numbers are going up, or is it a crab progression? So is this patient calcium going up? Their kidneys are getting worse. Are they getting more anemic? Most importantly, bone disease, which I think I can't tell the number of times people aren't getting adequate imaging tests, because you can check calcium, kidney, and anemia, but the imaging is the only way to pick up bone disease short of having pain. And we don't really want to wait for pain. If you know somebody's presented with bone disease, I really think it's important to try to at least get annual imaging of either PET or MRI so that you can keep up with that and make sure that the myeloma is in remission. We talked earlier in the Q&A about the genetics, also what kind of prior therapies have people had, side effects, how is a drug being given? Is it oral, IV, sub-Q, in the skin? Copays, we don't talk enough in myeloma. You come up with this great regimen and the patient's now $3,000 per month copay. Luckily, there's a lot of patient assistance programs, and I think treating myeloma really requires a team. Social work being an integral part, getting plugged into, luckily, a lot of our industry sponsors here have made drugs more accessible to everyone, but patients need to be aware of all of that. So clearly, it's not a one-size-fits-all. We have a huge number of drugs. We also have a huge number of factors to consider, so there's no one-size-fits-all. But just some general principles. So my take on current management of newly diagnosed myeloma, I think many people are getting VRD or maybe KRD, so bortezomib or Velcade with lenalidomide or Revlimid and Dex, that's VRD, and KRD being Kyprolis or carfilzomib with lenalidomide and Dex, perhaps especially for high-risk patients, those who might have neuropathy. I think very interesting data now coming out with the use of DARA with VRD, so this is a quadruplet. What's great about DARA in most clinical trials has been that it improves the results, but without adding a lot of side effects. And that's important because sometimes in medicine we're like, oh, let's keep adding more. Two drugs are better than one, 3 is better than 2. Well, therefore 4 must be better than 3. And that's not always been the case. We have previous examples where adding a 4th drug, for example, when you add cyclophosphamide to VRD, this was done in a study, it just added to more neutropenia or lowering of white count. Didn't improve the results, just caused more harm. And so more is not always better. Another great example, one of my favorite studies that was, again, a patient-initiated study was dexamethasone, right? Some of you may know this, the drug that makes everyone stupid, right? Dexamethasone 40 milligrams, if you convert it to prednisone, is 200 milligrams of prednisone. To put that into context, for patients getting asthma, COPD prednisone, they're getting 60 milligrams. So name another disease in medicine where you're giving 200 milligrams of prednisone daily for 4 days on to a median age of 65, right? It's really a terrible injustice, but it's because we didn't have a lot of drugs, right? Now that we have all these drugs, it was a patient that said, why are you torturing me like this? Show me the evidence that this is better. And guess what? That study, which was Revlimid with pulsing of this crazy 200 milligram prednisone or 40 of Dex versus once a week Dex, showed that yes, the responses with myeloma were a little bit better, but patients were dying of infections and blood clots. And so that study, which was patient-led, led to a complete change in how we approach newly diagnosed myeloma. So I would say for the exception of spinal cord compression and renal failure, we almost never use pulse dexamethasone anymore because we have all these other options, right? But that's another example of more is not better, but I think DARA VRD is really, there's a lot of controversy and depending on how people think, but I think this really already has shown that it's leading to deeper responses, this 4-drug regimen, and I think it's very well tolerated, and so I think going forward, this will be the standard of care. In lymphoma, for example, they had a regimen called CHOP, and then when rituximab was approved, R-CHOP became the standard of care. So I think in the near future, that's going to be changing. At this point, anybody who's transplant eligible, which typically is not a rigid age 70, but definitely 70 and below, and if over 70, very healthy, fit, should at least get the consultation and at least get the stem cells collected. Even if you decide you're averse to transplant, it's going to give us more options, right? That's another box in that table that I showed you, which is Melphalan. So it's a very effective drug, and I think it's important that we don't always throw out the baby with the bathwater, right? We keep adding all of these drugs, but a lot of the progress that's been made in myeloma is because of transplant. And so not everybody needs one, but at least have that consultation, hear about the risks and benefits, and decide whether you want to do it or not. And there's some emerging data maybe that if we're able to eradicate the disease using a very sensitive technique called MRD or minimal residual disease, so we've gotten rid of the blood proteins, gotten rid of the urine proteins, the bone marrow is negative, the imaging is negative, and now this fancy test tells us that at least we can't even detect 1 in a million cells of myeloma. Do we need to do that transplant? And so stay tuned, because I think going forward, we need clinical trials to really do this in a, what we say, prospective fashion, right? So if you're MRD negative, you get assigned to transplant or not, and we see, does it add anything? But until then, this is kind of our bedside approach right now. For ineligible, yeah,
Before you get off this page here, is that cell harvest?
yeah,
Harvest.
harvest. Oh yeah, sorry, typo. There's a V.
Do you do that before you start any treatment?
No, we, initial therapy, get that consultation, because initially, if we try to collect stem cells, we're not going to get enough cells in somebody who has a lot of myeloma in the bone marrow. So we want to clear that with the chemo and then do the collection.
Oh, okay.
Right. Yeah.
Thank you.
Sure. Moving to the transplant ineligible patient, I firmly believe everybody, regardless of age, needs rapid response to therapy, right? Just because you're older doesn't mean you should be suffering longer with bone disease and having more kidney problems. If anything, one of my favorite terms is time is kidney. Our best chance of getting the kidney function better is that initial diagnosis. And if that kidney function does not improve, that patient's long-term course could be changed because now they may not be eligible for clinical trials, which all have a kidney cutoff. So everybody really deserves active therapy. The newer studies are showing, so when we talk about older patients, there's I think sometimes a confusion about the doses and schedules of drug and the number of drugs, right? So those are separate issues. Older patients can get more drugs, just not at the same full doses and schedule that younger patients can, right? So for example, we see their VRD light. You can't give twice weekly Velcade, full dose Revlimid, full dose Dex to an 80-year-old person, especially in small 80-year-old women, because that woman could have normal kidney function, but the way we measure kidney function takes into account age, muscle mass, gender. And so the same kidney function in two patients actually has a different percentage of kidney activity. So what could be 99% function in a young patient, that same creatinine, which is our measure of kidney function, could be 30% in a small, older female, right? So we have to adjust drugs based on the patient's presentation. And I think the way we do that is by reducing the doses and schedule. Also, one of the challenges with older patients is because they have other things going on, like heart disease and other problems, these patients often don't keep getting to the next line of therapy. So that it's imperative that we really get that good first response and keep them in remission, and that's can be done by continuing treatment. When in relapse disease, as I kind of alluded to, we see diminishing returns, so we really want to get that good response. 3 drugs are typically showing better activity than 2 drugs. In some meetings with the FDA, it's been interesting because a lot of new drugs and drug companies say, okay, I have a drug X and I want to combine it with pomalidomide index. So I'm going to do X PomDex versus PomDex. Sounds great. But if study after study has already shown that 3 drugs, like something with pomalidomide and Dex is already better than PomDex, why are we using this old comparison, right? Why aren't we building on what we've learned? Why aren't you comparing your 3-drug combination with another 3-drug combination? And so I think that's one of the detriments of what's been clinical design. I think we really should be doing 3 drugs to 3 drugs. You can do a new 3-drug versus an old 3-drug, but let's not stack the favor in odds of every study getting approved by doing 3 versus 2. Which regimen you take really depends on what patients have had. So if you've had Revlimid or Velcade, maybe you want to, and you've already progressed on that, then you want to pick a regimen that doesn't have that, and that's kind of intuitive. And we talked a little bit earlier, 1114 translocation, I think, is our first glimpse into personalized medicine in myeloma. No one with 1114 should not get venetoclax, right? Because its benefit in the clinical trials, which was everybody got Velcade Dex and the other half got with the addition of venetoclax. Those patients who had 1114, the reduction in progression was 90%. That is almost unheard of, that magnitude of benefit. So I think that's really a game changer. For continued relapses, all of the above apply. Some of the things we do at Mount Sinai for patients who are progressing very quickly, maybe they've exhausted all the available drugs. We try to use 96-hour infusional regimens called DCEP or DPACE, as a way of getting the disease under control so that when you're entering the clinical trial and it's not as explosive. And I'll show you a picture of what that kind of looks like. We've also shown that people who had a transplant before and now maybe they're on their 3rd or 4th regimen and their counts are very low, we can do another transplant. Not because we're expecting that remission to last forever, but if we can clear up that marrow and the blood counts improve, they can then go on to an exciting clinical trial like CAR T or bispecific, which you're going to hear from Dr. Berdeja. But if that patient is stuck with these low blood counts, they're not going to be eligible for any studies. And even doing regular chemo can be challenging. Because, for example, if you're starting pomalidomide or Pomalyst in a patient with low blood counts, you're going to be basically stopping and starting. It's like a very jerky ride because the counts are going to drop, and then you're going to hold, and then you're going to stop. And meanwhile, the cancer is not adequately controlled, right? So a second transplant can be very useful in that setting. And then just novel agents, selinexor, just this week got a press release showing activity in combination with Velcade and Dex. CC220 or iberdomide, a next generation IMiD. Dr. Verdeja is going to talk to you a lot about these anti-BCMA drugs, so a lot of really exciting treatments. And I would say throughout the continuum, we need to do clinical trials. And as you heard, not just the clinical trials, but also understand the basic science. Why is this patient responding to this drug and not responding anymore? Those questions really need to be answered. So moving a little bit to the future, and I think I'll start with this smoldering. There's this joke that if you ask 6 myeloma doctors for an opinion, you get 10 answers, right? And this is one of the most controversial fields, and this is just my particular take on it. But I would start with the premise that smoldering myeloma patients don't have active cancer yet, right? And one of my least favorite analogies, which is used even by prominent myeloma key opinion leaders, they say, well, if you have early breast cancer and colon cancer, you're not just sitting there, you're taking those out. So why aren't you treating smoldering myeloma? That is a very irresponsible analogy because we don't treat other blood conditions that are asymptomatic. So for example, chronic lymphocytic leukemia, myelodysplastic syndrome, follicular lymphoma. These are early B-cell cancers or blood cancers that we're not treating. Right? So just because we find it doesn't mean we should jump on this bandwagon of treating everybody, and certainly not because we hack out solid tumors, right? So early lung, breast, if you take a nodule out, you can get rid of it. What are you doing when the cancer is affecting the whole bone marrow? You're not taking out a bone marrow, and do you need to expose this patient to risk? And I think it's incumbent on us to show that we're not hurting this patient, right? So I've sat for many years on what's called the Institutional Review Board, where we review consent forms, and the job of us in that board is to make sure that this patient who's signing that consent form understands completely what are the risks and benefits of this treatment. And just because we have drugs doesn't mean we should be treating people. And so what you can see on this graph is that at the bottom is MGUS, which just shows that generally the rate of progression from MGUS to myeloma, meaning CRAB symptoms, calcium, renal anemia, and bone, is generally very low. And it's pretty linear, right? It just kind of starts off low. And you could, it's 21% after 20 years, which means if you have MGUS, 80% of patients are not going to progress to myeloma. And it's very possible if your MGUS is diagnosed at the age of 70, you may have a natural lifespan, and this is an incidental finding. When we go to smoldering myeloma, the curve is very interesting. It's very steep, and then it flattens out, right? And that steep part is where we really need to do a lot of work. And we need to figure out who are the people that are progressing. But then once you get past that, that looks like MGUS, right? So we need to figure out who's going to progress and who's going to end up with MGUS. And if we don't get that risk stratification correctly, we're going to be really over-treating a lot of people or under-treating a lot of people. And so this is one of the efforts. And believe it or not, this was decided in an International Myeloma Working Group, which all of us, I think, are members of. And there was a panel that discussed, okay, let's try to figure out, we all agree that if there's a patient has an 80% chance of progressing at 2 years, we should be treating them, right? So if you're diagnosed with smoldering myeloma and you have almost a guaranteed chance of converting to myeloma, and we have such good drugs, why wouldn't we treat those patients? And it kind of makes sense. Bone marrow, more than 60%. If you had a lot of myeloma, you can see in this table, 90% risk of 2 years. If your free light chain ratio is greater than 100, 80%. If you have more than one focal lesion on the MRI, 70%. But guess what? We looked at this data. We had about 300 patients at Mount Sinai with smoldering myeloma. In our hands, bone marrow more than 60% was only 41% at progression at 2 years. Free light chain ratio greater than 100, 44%. The MRI focal lesions, the Germans presented data that even if you have 2 lesions on the MRI, if you repeat an MRI 6 months later and there's no change, that patient only has a 15% risk of progression. So look at the complexity in this very, what seems simple, 60% marrow, free light chain greater than 100. And these criteria are also, if you think this is confusing for you as patients, it's confusing for community doctors. I just got a call this week, and I saw a patient from a community doctor, and she said, look, I have this patient that has a free light chain ratio greater than 100, so I'm just wondering what I should do. It's like, well, tell me about your patient. How long has she had that? And she said, oh, maybe a little over 2 years. I said, well, by definition, then this patient is not high risk, right? She hasn't progressed and you've known about it for 2 years. That's what this criteria was intended to use, right? And this was supposed to be the crystal ball, like, okay, my crystal ball, if this person's gonna progress in 2 years, I should be treating you maybe. But if you've already passed that, well, what is the use of that crystal ball, right? And adding to that, we don't give Oscars for best photograph, it's best movies, right? And so look at what happens on the left. This is our data from Mount Sinai. When you look at free light chain ratio over 100 and under 100, there's a clear separation that those who are over 100 are progressing than those who are less than. But we did it a different way because in medicine, I hate these random binary numbers. Who decided 100? Why not 60? Why not 125? What's the rationale for that number? And if you're 101, is that different than 99? And what does that mean? We decided, let's not pick an arbitrary number. Let's use information technology. Let's let the computer tell us what we should do. And the computer, basically, we just entered the raw data, similar to kind of Health 3 University, and he said, computer, tell us who's going to progress and who's not progressing. And what the computer did is it generated two curves. The top curve is patients whose light chains were rapidly increasing, and the bottom curve, those who weren't. And doesn't that make sense? If your numbers are taking off, this is concerning. If your numbers are high, but they remain flat month after month after month, what does that mean? And this isn't unique to myeloma. Prostate cancer, there's a term called PSA doubling time. CLL, there's a lymphocyte doubling time. In general, in oncology, we look at the rate of cancer development and not just an initial time point. And so I would argue that before we commit patients to treatment, why don't we at least just see what happens for a little bit of time? Is this patient stable or not, right? And what we did when we integrated what's called multivariate analysis, we looked at a bunch of different factors, and you can see that what really came out was evolving hemoglobin, evolving M-spike, evolving light chain. So these are things that are changing. They don't meet CRAB criteria, but the patients that were rapidly evolving, if they had all of those factors, they were almost guaranteed to progress. If they didn't, not. And this did not include free light chain ratio than 100, did not include marrow more than 60%. So I think we have a lot of work to do. And not only all of that stuff, but these patients really have a different biology. In the interest of time, I'm going to slip to this next slide and I think close this discussion with in the future. I don't think we're going to have smoldering. I think patients are going to be MGUS or myeloma. This in-between hazy category is really not helpful. There are some smoldering patients who are behaving like MGUS, and there's some that are myeloma, and it's our job to figure that out. But it's not just with easy numbers like free light chain ratio and marrow. It's going to require following that patient, understanding the disease biology, and that's how we're going to make some progress. So what are the unmet needs right now in myeloma? Frail, elderly. So we've made a lot of progress, but these are the patients whose overall survival curves are lower than the rest, right? So while we're working towards a cure, which we all agree needs to be done, in the short term, we need to focus on those patients who are not living as long as others, and those are frail older patients, renal failure, extramedullary disease, and high-risk patients. So I've kind of been talking about this, which is that not every patient will get to the umpteenth line of therapy, and the remission durations shorten. So we really need to use effective therapy, and in particular, it's the frail elderly and renal failure and high-risk patients that aren't able to get to their umpteenth therapy. So what is the way we can attack that for elderly? Here's a great study, daratumumab with lenalidomide and dex. The top line is the addition of dara to RD or len-dex. The bottom line is just the doublet. These patients in dara-RD are doing so well. You can see the curve is just remaining flat. We don't even have a median yet. And I think this is what the future is going to be for these patients. And we're doing clinical trials to even add yet another drug, which is bortezomib, once weekly, because we know that RVD light is good, so we have a clinical trial for that. For high-risk patients, I think this is very important, and I just want to spend a moment on this because there's a lot of misconceptions, even amongst physicians. So in the top left panel, this is a hypothetical comparison of standard risk and high risks. So in the top left panel, you can see that the high-risk patients with the dotted line do worse than the standard risk patients. Now, when we do a new treatment or new clinical trial, there's three possible options. The one on the upper right, adding a new drug might actually worsen the outcomes of high-risk patients, and that's why you see that dotted green line is the lowest of all. And you may not think this happens, but this actually has happened recently with venetoclax patients who were high risk did worse. There was more deaths in high-risk patients. So thalidomide in high-risk patients has also had some data. So this is definitely not what we want. Then in the lower left is patients with high-risk data. They do better than they would have without it, but they're still not doing as well as standard risk, right? So the green solid line is the best one on this curve. Our goal really needs to be this right panel. We shouldn't be able to tell high risk from standard risk anymore, and the green lines are superimposable. So that's the dream, and until we get there, we have a lot of work to do. And suffice it to say, in the interest of time, and again, I think we can do it in QA, none of our drugs have really overcome high risk. The closest we've come is with drugs like Velcade and carfilzomib overcoming 414. So that's why that translocation is actually now considered intermediate risk, because we have drugs that we think can overcome them. And so I would say what we need to do for these high-risk patients, this is where even if a regimen is potentially risky or toxic, we need to move these quickly up earlier for high-risk patients. So such as CAR-T, BiTEs, selinexor, which are typically started in heavily treated patients. But since we know these patients aren't doing well, these are the patients that we should be testing as quickly as we can so that we can try to get their curves better. And then just briefly, the roles of clinical trial. I think this is the most important slide. You've heard all of these drugs approved. This is what it takes. So first, in the laboratory, doctors like Fotis are working on preclinical data in their mice patients and showing that this drug works. That can take up to 4 years. Then they submit an application to the FDA. It's called an IND. And then you get to phase 1 testing. Phase 1, what's the right dose? What's the schedule? What's the safety? Typically small studies, 20 patients. Then you get to phase 2. How well does this work? Then you get to phase 3, which is how does it compare to regular chemo? This takes 8.6 years and many, many millions of dollars, right? And so given, again, how rare myeloma is, it's really amazing the number of drugs that have gone through this process, right? And, but I think this is why really every patient, if there's a clinical trial that's available, please consider it. What kind of patients? Phase 1, relapsed refractory disease, because we don't know the safety yet, so typically we start with advanced patients. Phase 2 could be in newly diagnosed or relapsed, because we're looking to see if this drug is, how well it works. We know the right dose. And phase 3 could be for anyone. And then this is the slide I was referring to. When is the right time to do a phase 1 study? And I think it's really a shame because not all phase 1 studies are going to work, right? And if a patient enters a clinical trial with explosive disease, like at time point 3, it's a disservice to the patient and the drug, because if that patient has a lot of symptoms, you don't know what's coming from the drug, you don't know what's coming from the patient. By the time you screen and start a treatment, the disease is so explosive. That's where we try to use these 96-hour chemos, salvage transplants, use these aggressive regimens to knock the disease down. You can't enter at 1 because there's no disease, but the minute it goes up, that's the ideal time to enter a clinical trial. And then you're giving both the patient and the drug a chance to work, right? So I think that's really great, important clinical trial management. And I think because I'm limited with time, I will stop there and just important things to think about as a patient when you're thinking about clinical trials, how to be a good study patient. And I think here, what you should ask about these clinical trials, which is obviously side effects and benefits. What does it change any of your other medications? Who do you call for complications? And the big ones from a lot of patients are clinical trials cover a lot of the stuff, but they don't cover everything. So for example, if you're giving novel drug X with POM-DEX, the POM-DEX may come from your insurance. So it's whatever copays you have for POM, whatever copays you have for DEX, the drug is covered, but then you have to figure out, before you sign the consent form, how, work with the team and figure out what will be your out-of-pocket costs, what are your copays for coming to the institution, is there any reimbursement for time and travel? So I think those are things to think about. But I think together we can continue to improve these progress that we've had and really get to that cure that we're all looking for. So with that, I'll stop and thank you for your attention.